This portion of CardioSource Video News is supported by the makers of Xarelto.
Welcome to ACC 12. I'm joined now by a friend and an old colleague, Dr. Bill Weintraub. Bill is the Chief of Cardiology at the Christiana Care Health System in Newark, Delaware. Bill, thanks for joining me.
Randy, thanks so much. Good to see you again.
Good to see you. And this is a very interesting sort of use of data banks and data registries to look at comparative care, really comparative effects of different types of revascularization strategies. Tell me a little bit about it.
Yes, well, it is. I think that this is really sort of your most typical comparative effectiveness research study using observational studies. Now, this is a major collaboration of the American College of Cardiology Foundation and the Society of Thoracic Surgeons. As you well know, each of these societies has large databases. The total number of patients in these databases now is over 15 million.
That's incredible.
But the databases themselves, the data are short-term. So to look at long-term outcome, we've linked both of these databases to the CMS, Center for Medicare and Medicaid Services, 100% denominator file. In other words, essentially to Medicare data, which gives us long-term outcome, but also downstream resource use. And then we used advanced statistical techniques to allow us to make these patient populations look as similar as possible. Since this is observational, it's not randomized.
But you're really looking, so it's a sizable study, very powerfully, powered powerfully, and you're really looking at comparative effectiveness of two different PCI versus CABG in this population base?
That's correct. So this is the most generalizable look that anyone has ever conducted, using also quite contemporary data to study these two forms of revascularization. There have been clinical trials in this space, but only about 10,000 patients total. Some of the trials are quite old. You remember the East trial?
Sure.
That's now that's now 25
years old. Yeah.
And the most recent is Syntax, of course. That's the only one that used drug-eluting stents. So while using observational data, we have the most generalizable data. We have a much larger data set and quite contemporary data.
So Bill, the zillion-dollar question is, what did you all find in this?
So what we found was, in this particular presentation, we looked at mortality. Total mortality. And what we found was that at 1 year, there was no difference between the two treatment arms. But at 4 years, there was a survival advantage to coronary surgery. 20% absolute reduction in mortality, rather 20% relative reduction in mortality, 4% absolute reduction in mortality.
And Bill, these were tell me the age, sort of the age brackets. These were older age individuals, is that correct?
Yes, these are patients 65 and above, because these data were linked to Medicare.
Medicare data. And were there any pertinent exclusions for our audience to know about?
Yes, these were patients with stable ischemic heart disease. So these data do not apply to patients with acute coronary syndromes.
It's a fabulous study and very well done, obviously. But so how does this impact our practice?
Well, the first thing to understand is observational, and we did everything we could to control for treatment selection bias, but you can never overcome it completely. So there may be residual treatment selection bias. One of the things that I think is also important to understand is how this fits in with what we knew before. Because most of the studies actually in higher risk populations have previously suggested a survival advantage to coronary surgery compared to percutaneous coronary intervention. Nonetheless, despite all of the data we had before, there's been a move towards more percutaneous intervention and less coronary surgery. This will probably shift it back a little bit. And actually, as Alice Jacobs pointed out in the discussion today after I presented my paper, that the results of ASCERT are actually consistent with guidelines. So maybe this will help us do a little bit more of what we should do. I think this will increase the discussion between the surgeons and the interventionalists. I think that's a good thing. And I think that shared decision making that includes surgeons and interventionalists and patients, mostly patients, is really the right thing to do.
Well, I congratulate you, because not only is it a well done study, but it really shows combining data banks from two different societies, cardiologists and cardiac surgeons, it really does drive our practice in the right direction, I think. And so congratulations to you. Thanks very much for joining us. And thank you all for joining us. Stay tuned. We'll have more for you from ACC 12.